Test 1 2. Test 1 2 1 2 1 2.
Good afternoon. We've got a lot of ground to cover, so I think we can go ahead and get started. I appreciate the opportunity of giving this grand rounds, the opportunity of being part of the medical staff here at St. Vincent's. It's only been about 9 months now, but you have my bio, so I'm not going to belabor that. The topic today is chronic lower extremity ulcers and advanced wound care. And the goal that I've set for myself is to kind of take you on a wild and wonderful tour of chronic wounds. Wounds and ulcers are, for the purposes of this particular lecture, will be interchangeable, although there are people who would say that you should use them differently. But the idea is to give you some sort of a conceptual framework of how to think about chronic wounds, what causes them, how we can recognize them, what are some of the common factors that lead to chronic wounds, and what's the hoopla about advanced wound care. Is there really anything to this, or what do we know and when did we know it? And so we've got a lot of slides to cover, and I'll go ahead and get started. If you can't hear me in the back, or you need to get up and walk out for anything, just let me know, or I won't get my feelings hurt. So this guy is pretty proud of his skin. He's as well he should be. This is the skin is the largest organ in the body. It's our first line of defense against whatever we come into contact with in the external environment. People have been wounding and being wounded for as long as there have been people on the earth. So the skin is very important as sort of our first line of defense, our first responder. It has all sorts of elements in it, which we'll look at in just a second. And it also has an acid mantle, which is made up of sebum and other materials that's slightly acidic, 4.5 to 5.5, and helps to protect us against microbes. So for a definition, a wound is a disruption of normal anatomic structure and function that's usually inclusive of the skin. So it's hard to wound people without involving the skin, although it's conceptually possible. And wound healing should result in restoration of anatomical and functional integrity. Doesn't always. There are all sorts of different kinds of wounds. This one you're familiar with, that's not us. This one is probably not going to be helped by us, but we see a lot of these. And I should mention the one on the bottom, the pressure ulcer, we're not going to talk about today. I've just chosen, that's sort of a course unto itself. So we're going to focus on the diabetic foot ulcers, venous leg ulcers, and arterial ulcers. And there are also some ulcers that just don't fit into that category of three that I just mentioned, and they are the so-called atypical ones like pyoderma gangrenosum. You see some down below some examples of chronic ulcers and some characteristics. They're non-healing or slow to heal. We think about the normal healing process as being over the course of maybe 4 to 6 weeks, depending upon the size of the wound. I'm going to run you through a real rapid course in normal wound healing in just a second. But the cause is ongoing. That's very important, because the things that are unique to some of these wounds are that the cause is a constant ongoing process, so recurrence is very common. And there are also multiple systemic and local impediments to healing. So chronic wounds, as I mentioned, have failed to proceed through an orderly and timely process to produce anatomic and functional integrity, or they have healed but they haven't healed with normal function. Okay, this is one of those extent of the problem slides that usually goes right over my head, but just suffice to say, this is a big problem. 1 to 2% of the whole population of the United States will have a chronic wound during their lifetime, and that's like 6.5 million people, a whole lot of healthcare dollars expended on this problem, whether it be for wound healing or for revision of scars after the wound has healed. So if you look just at diabetic foot ulcers, 25% of all diabetics will develop one during their lifetime. It's very costly per ulcer. Again, there's a high recurrence rate. Amputations cost a lot of money, $38,000 plus. This is in 2009, so it's more than that now. So if you, like me, were maybe one of those people in professional school who was asleep during this lecture, let's go back through the skin for just a second and talk about, there's a lot of stuff that goes on in the skin, a lot of different elements. So the squamous epithelium, the squamous layer, the epidermis is the first level of skin that you get to from the outside, and it's composed of squamous epithelium. There's a cool little feature here, right here, where you see the up and down, and that's reedy pegs or reedy ridges, which sort of fit together like your, oops, what did I do? There we go. Fit together like a finger joint and keep shear forces from causing skin tears. In children, very young children, and in elderly people, the reedy pegs and reedy ridges get smaller, so skin tears are more common. There are some cells there in the epidermis, including keratinocytes, which will be very important in what we talk about later. Marginal keratinocytes are the cells that have to do with covering a wound with new epithelium. So the dermis is the second layer, and the dermis is really sort of where it's at when you're talking about the skin, because there are just numerous organelles in the dermis. Hair follicles. One cool thing about this is that there are epithelial cells down into the hair follicle, and you can regenerate epithelium from there if the hair follicle is still there. There are venules, there are arterioles, there are fibroblasts and tissue macrophages, and the ECM, which is sort of the what's left over after the other organs or organelles have been accounted for. And then the subcu or the hypodermis contains arterioles and venules also. So one way to think about the skin is, if you get an injury and it bleeds, then you know you're at least into the dermis, because the epithelium, the epidermis, doesn't have blood supply. It depends upon the dermis for nutrients and for whatever it needs from the blood. So let's run through normal wound healing just very quickly. Again, this is a highly orchestrated thing. I've been listening to podcasts about World War I and World War II in my driving back and forth, and this is sort of like a very, very well executed military campaign where there are all sorts of different troops and communications, and it really is a thing of beauty to read about how normal healing takes place. Of course, it starts out with an injury and ideally ends up with a healed wound. The cytokines are vasoactive substances that are released by different cells and sort of call the shots, communicate between different cells to call the troops in that need to be involved in that particular part of the campaign. So the initial part of normal wound healing is hemostasis. You get a wound, you bleed if it's into the dermis, and what happens, prothrombin turns to thrombin and fibrinogen turns to fibrin. Fibronectin is involved. There's a fibrin plug that sort of tries to staunch the bleeding. Platelets are caught up in the fibrin plug. You'll see there. And they help coagulate and stop the hemorrhage. The next phase is inflammation, where because of some of the cytokines, again, that are involved in the wound healing process, then the cells come that need to be there for that particular stage of healing. You can see there in the bottom right, platelet-derived growth factor and another cytokine are involved in getting cells there and in leading from the inflammatory stage to the next. One problem that we see with chronic wounds is that they get stuck in this inflammatory stage of healing, and that's the reason that they become chronic. So platelet-derived growth factor is one of the vasoactive substances that I mentioned. When platelets degranulate, they release platelet-derived growth factor, and it sort of is like the person who's leading the orchestra and is sending signals to all sorts of different cells to do what they need to do to get the wound to heal. I want to mention also proteases, because you'll see later on MMPs, which are matrix metalloproteases. They have a normal function in wound healing where they come in and cleave protein when it needs to be cleaved and participate in the normal process, but they also are bad actors if they hang around too long and tend to perpetuate the inflammatory phase of wound healing. And then you need new blood vessels to form. That's, again, part of the later stage. Angiogenesis is part of the later stage of wound healing. And VEGF down at the bottom of that slide is vascular endothelial growth factor, and it again is one of the elements that helps to direct that particular part of the healing process. The next stage is proliferation, where again normal healing is continuing. You can see the cells that are involved. Contraction has to do with the wound contracting because of the activity of myofibroblasts and elements called microtubules and actin and myosin. And you can see on this mouse's back how that wound or ulcer is contracting. And then finally maturation and remodeling. And this, plastic surgeons will tell you that the remodeling of wounds and scars can go on for months and even a year or more after the wound is healed. That involves the flattening out of the scar and turning back to more nearly the color of the surrounding skin. So again, that's what we want to see if everything works as it should be. But for some reason, some wounds don't heal like they should. They become chronic and non-healing. And we might ask the question why that happens. I realize the print on this is small, it's difficult to read, but you have a copy that maybe you can make out. Again, the idea is to point out that there are common chronic wounds, venous leg ulcers, arterial ulcers, and ulcers related to the polyneuropathy of diabetes. There are also people who have polyneuropathy who are not diabetic, but more commonly diabetics. And the last one is a pressure sore, which again we're not going to talk about. That's a lecture to itself. So what are local factors that affect wound healing? Ischemia is important. You know, it's something that we always try to keep in mind in the wound center because it's so commonly involved not only in arterial ulcers, but it's also a contributing factor for both diabetic ulcers and for venous leg ulcers, not uncommonly. Infection can be a local factor. How do you decide if a chronic wound is infected? Well, what you don't do is just swab the wound and send that for culture and treat whatever you get back from the lab, because all wounds beyond, just post-injury are going to have a positive culture for something, and that doesn't necessarily mean they're infected. So what you want to do is to get a better specimen for culture, and that could mean that you debride the wound and then you get a culture post-debridement, or even better that you get actual tissue to send to the lab and do a quantitative culture. If you get a quantitative culture done and you find that there are 10 to the 6th or more organisms in the culture, then that is very suggestive of infection. Or if there's any beta hemolytic strep at any level, that's also considered infection. Edema is very common, not just in venous leg ulcers, but in others. Scarring, radiation injury is common. That's a common thing that we see. People who've been irradiated for some other reason and then get an injury. People like to put stuff on wounds. There's a lot of folklore out there about how do you treat a wound, because, again, we've been dealing with wounds for eons. Some people will say leave it open, let it dry out, let it scab over and it'll heal. Some say put alcohol on it. Some say soak it in Epsom salts. And it's true that some of those wounds will heal after that kind of intervention, but I think you'll find that those wounds are healing despite those interventions and not because of them. We know more about what wounds need now to heal than we did 20 years ago. We know, for example, that wounds need to be moist, not too wet, not too dry. They need to be clean, cleared of devitalized material, so debridement is important. They need to have infection treated if infection is the problem. They need to have the root cause addressed. And then you need to think about things like foreign bodies. I had a patient a year or two ago who was impaled by a root or a stick while he was on his zero-turn lawnmower, and he came to me several months later saying this wound just won't heal, and he'd been seen and given antibiotics and so forth, and it was not until we got the rest of that stick out of his leg that the wound finally healed up. Not visible on plain x-ray. Local malignancy is an important cause of non-healing wounds. You need to think about that. There's a wound or an ulcer called a Marjolin's ulcer, which is a carcinoma, squamous cell carcinoma at the site of previous injury or scarring. And if you don't biopsy, you don't think about it, you don't find it. There are also systemic factors that affect wound healing, and these will be very familiar to you. diabetes, and especially non-controlled diabetes, smoking, because smoking has immediate effects as well as chronic effects. Every time you take a drag off a cigarette, it clamps down blood vessels, makes a difference in your body's ability to heal. And then all sorts of other things, again, that are commonly seen in especially hospitalized patients, but also patients in the wound center. And we'll talk about those some more in the slides to come. There are also biological and chemical defects like deficient growth factors, which may be seen in diabetics who are not controlled. Sometimes there are people who can't make granulation tissue. Say, for example, they're malnourished. Is it possible for an obese person to be malnourished? Yes, it's very possible, and in fact not uncommon. And I want to point out the last thing there, the excessive proteases, or the MMPs. I mentioned those earlier. They are part of the normal healing process, but if they accumulate and they hang around longer than if they sort of overstay their welcome, then what they do is they keep the wound stuck in the inflammatory phase of healing, and that makes it plateau and not heal. So MMPs we need to address in some way by debridement or by other methods in order to remove them as a cause for non-healing wounds. And then I want to highlight hypoxia. We talked about ischemia earlier, and the fact that a lot of wounds are hypoxic because they have poor arterial blood supply. There are other reasons for wound hypoxia, but there have been studies done that have shown that if your average PO2 in tissue is less than 40 millimeters of mercury, then wound healing is impaired. In fact, a PO2 in the tissue of 20 is used sometimes as an indication of this is where you need to amputate. Okay, this is a depiction of a gentleman by the name of von Leeuwenhoek, who back in 1684 was playing around with microscopy. He's the father of modern day microscopy, ground his own lenses, and he sort of figured out some way that just swishing vinegar around in his mouth did not remove the little animals, which is what he called the bacteria and other things he saw under his microscope, didn't remove those totally. And he seemed to have had an idea, some inkling that there was some reason that this stuff was stuck there and not being washed away. And now we know that what causes that problem in dental plaque is a feature called biofilm. And biofilm has been in the news in wound healing now for the past few years. There have been literally thousands of articles written about it. When the germ theory of disease was propagated, people assumed that the best way to study and to treat bacteria and other microbes was to grow them in pure culture on something like an agar medium and then test them in whatever way they were able to test them at the time. Now, of course, against antimicrobials by Kirby-Bauer techniques or other techniques. But now we know that this is a confocal scanning light microscopy image of mature biofilm. And what you can see is that there are different organisms here, dried acanthamoeba and rod-shaped bacteria in this one. And you see this substance that's on the surface here, there are actually bacteria and other organisms that are attached to the surface, and then there are other architectural elements in biofilm like water channels and columns to hold it in place. And there are microcolonies of different organisms that are in the biofilm. And this stuff is hard to wash away, hard to remove, and can regenerate within hours or a day. These bacteria are in what's called a sessile state, not planktonic. Planktonic is the way they grow in agar, and these are in the sessile state. And as you can see in this cartoon, there are different bacteria, and the different ecological sites that they grow in the biofilm may be more anaerobic, more aerobic. They can swap genetic material in the biofilm. They can use whatever tricks they have up their sleeve, such as the production of beta-lactamases to protect not only themselves but other bacteria. And they can also, when they reach a critical mass, they can bud off planktonic bacteria that forms new biofilm in another spot. So biofilm is difficult to culture, tolerant of biocides, tolerant of antibiotics, capable of regenerating, and one of the reasons that chronic wounds don't heal. So if you swab biofilm and you send it to the lab, you may get you'll get something back. I mean, there'll be something that's growing on culture, but you probably will not get all the different organisms that are involved in the biofilm. And so other methods, newer methods like molecular methods to use RNA or DNA to try to identify which organisms are there, help to determine really what's in the biofilm and on the wound and what we might do about it. Microbicides like cadexamer iodine, which is a form of iodine it's different than povidone iodine. It's released very slowly, and it's been shown to have some activity against organisms in biofilm. So here's just some facts, some quick facts about lower extremity ulcers. We generally divide them into leg ulcers and foot ulcers because there are different etiologies and different management techniques, different chronic problems. And let me take just a second to commend to you this article by Singer, which is in the October, I think, 19th or 18th edition, 2017 in the New England Journal. It's about lower extremity ulcers, and it's a review article which I would commend to you as just a good review. So they make the point in that article that 70% of leg ulcers are venous etiology, 20% are mixed arterial and venous. And if you look at foot ulcers, 85% of those are related to peripheral neuropathy, often complicated by arterial disease. So again, a common factor with arterial disease. And 25–50% of leg ulcers and more than 30% of the foot ulcers are not healed after 6 months. Here are risk factors for venous leg ulcers. I won't read those to you, but it's interesting that there are families that tend to have venous disease. And people who have previous leg injury, like I'm seeing a patient right now who got shot in the leg years ago. He was a law enforcement officer, and he had all sorts of arterial and venous injury. And So he is having trouble healing a leg ulcer now partly because of venous disease. So chronic leg edema is a common factor in venous leg ulcers. Risk factors for arterial ulcers, diabetes is a big part of that because of its tendency to cause arteriosclerosis and small vessel disease. High blood pressure, again, because of atherosclerosis. Hyperlipidemia, same reason. Obesity and cigarette smoking we've talked about. Risk factors for foot ulcers, lack of sensation. I mentioned earlier that diabetics are the ones that mainly we see with polyneuropathy, but there are other people, and I again have a patient right now who has an idiopathic neuropathy that acts just like a diabetic neuropathy, and he has a foot ulcer that I'm having trouble healing now because of that. Limited joint mobility sometime in diabetics. They get heel cord shortening sometimes. They walk funny on their feet because they can't feel where they are. And again, they have vascular disease and recurrent injury. So here's a comparison of a venous ulcer on the right and an arterial ulcer on the left. The venous ulcer is shaggy and irregular in shape. The arterial ulcer looks more punched out and deep, can have an eschar on the surface. You never say never, but it's very, very uncommon to see an eschar on a venous ulcer. They're more wet, and arterial ulcers tend to be more dry. So how do you evaluate for arterial ulcers? Non-invasive studies, angiography, vascular referral. It's very common for me to refer somebody if I have any concern about arterial disease for a vascular surgery evaluation. The non-invasive studies that you want to order have to do with Doppler ultrasound. This is from that article by Singer, and it shows how you do an ankle brachial index determination. You use a Doppler. You get a systolic pressure from the brachial artery, and then you get pressures from the dorsalis pedis and posterior tibial arteries at the ankle, and you divide the ankle by the brachial, and you get an index. 0.9 to 1 is normal. If you get down to 0.8, you're concerned about the possibility of arterial disease. 0.7 and below, you're really concerned. 0.5, you better be getting them to a vascular interventionalist quickly. If you get above 1.2, if you get to 1.3, then probably what that means is that they're diabetic and they have calcified non-compressible arteries, and you're getting bad data. So it doesn't mean they've got great flow. It means they probably don't, or you can't tell. So venous leg ulcers definition, I won't go over that with you. It has to do with venous disease. Again, this is what a venous ulcer looks like. Interesting to note that you can tell better on this side because of the skin pigmentation, but they tend to have hemosiderin deposition in the distal half or distal third of the leg. They tend to occur in what's called the gator distribution. Gator, not like Florida gators, but like G-A-I-T-E-R gators, which were pieces of clothing that people used to wear. Actually, sailors used to wear gaiters as part of their dress uniforms. I don't know if they still do that, but they basically cover you up from here down to the ankle. And so the gator distribution is suggestive of venous disease. And of course, this poor fellow has huge varicose veins, and there's nothing subtle about that. So how do we manage venous leg ulcers? The main thing that we do, the main thing we have to offer is compression, meaning we use compressive bandages. There are all sorts of different ones of these. There are 2-layer compression, long stretch compressive bandages, 4-layer bandages, 2-layer light bandages, 4-layer light bandages, short stretch bandages like the old Uniboot that doesn't stretch a lot but depends upon the calf muscle pump. So when you get up and walk about and you're pumping your calf muscle, then the Uniboot helps you send blood back in the right direction up toward the heart. Ablation therapy can be done now. This is taking the place of vein stripping, which is, as I understand it, pretty much not done. But endovascular procedures using microwave energy or laser energy to ablate vessels is one of the ways of treating this, and I made note there that there is new data that shows benefit. This was actually in about the April or May issue of the New England Journal, where there was a study from the United Kingdom that looked at about 20 different sites, 450 patients, and looked at early intervention with early ablation plus compressive therapy, and compared that to late ablation, like after 6 months, plus compression. And the early ablation showed a benefit to healing, that like 56 days versus 80-some days for the late intervention, and showed a decreased amount of time, or I'm sorry, an increased amount of time to recurrence. And the healing at 6 months was better in the early intervention group also. So all that plus standard wound care. I think we've talked about most of this. 16 to 20 weeks average time to get something to heal. These are just some of the bandages that I mentioned to you, and mentioned about traditional surgical interventions that didn't have great results. Again, we use ultrasound to try to determine if somebody has venous disease. You don't always get a positive ultrasound test, but if you get an ultrasound test that shows incompetent vessels, like the cartoon on the far right, where blood is refluxing back and forth here, then that's venous disease. Diabetic foot ulcer management. There are cellular failure mechanisms that you can identify. You all know about how protein gets glycated or glycosylated, leading to glycosylated hemoglobin. There's accelerated atherosclerosis. When you have blood sugars over about 200, leukocytes don't function well, they are lazy. There's poor platelet aggregation, and then there again altered patterns of growth factor and growth factor receptor expression in diabetics. They don't form collagen well. Fibroblasts normally form type 3 collagen in wound healing, and eventually it becomes type 1 collagen, which is the most common collagen in the body. And there's also impairment of angiogenesis. This is too small to see, but this is a Wagner grading scale that we use for naming diabetic foot ulcers. It's not a great scale. It's used mainly because the Center for Medicare and Medicaid Services decided that's what they were going to use. And if you're going to use interventions like hyperbaric oxygen therapy, you have to have at least a grade 3 Wagner ulcer in order to justify that. So this is the Wagner scale, and you notice that the difference between 2 and 3 is that they're both about to the same depth, but 3 has infection involved. So that says a 1 or a 2 plus infection is a 3. I would have some problem with that. I think a 2 plus infection is definitely a 3. So how do you assess for the ongoing cause of problems in diabetic feet? The main thing is you decide whether they have diabetic polyneuropathy or not. This is a Sims-Weinstein test. It uses a 10-gram monofilament, and you just put it in different spots on the foot and press down enough to bend the monofilament and ask the patient if they can feel it. What you tell them is, close your eyes, I'm going to touch your foot, tell me when you feel something. And if they say something when you're not touching, or you touch and they don't say anything, then you know you've got problems. These are offloading devices. Offloading is one of the main things that we can do to help diabetic ulcers, because again, they walk funny on their feet. They're different. They're pressures and injuries that are repetitive. The thing at the top is the gold standard, and that is the total contact cast. If you can't, for some reason, or the patient won't allow total contact casting, then you can use a removable cast walker, which has Velcro straps there, and is supposed to do the same thing, except for the fact that people don't wear them like they should. They take them off and they walk around the house and walk to the bathroom without the boot on, and then they don't get the result that we're looking for. So you can try to make it into more like this by putting some sort of tape or what you think is not removable around the cast walker, and that helps some, but it's not as good as the total contact cast. So this is a patient of ours at one of the clinics, I think the Birmingham clinic, just illustrating again how these are complex patients. This is a lady who fell up her stairs, not down her stairs, fell up her stairs and really caused a pretty bad wound on her leg. And the problem with her is that she has ankylosing spondylitis. So she has a chronic inflammatory process going on that impinges upon her ability to heal. This is another patient also at the downtown clinic who when she first came to see us, had what we knew was cutaneous sarcoid because she'd been diagnosed some years ago. She also has venous disease, but then about the first or second visit, she also found out she had breast cancer. So she is on chemotherapy for her breast cancer, she's on treatment for her sarcoid from her dermatologist, and she's on treatment for her leg ulcers from us. And as you see, we still have a ways to go with her. So there are times when you have to look for ulcers that don't fit the typical pattern. They don't look, I mean, for some reason they don't fit exactly venous or arterial or diabetic foot ulcers. So if they present in some atypical way, or there's a disease that points to a shared etiology, like, let's say, for example, some sort of chronic inflammatory disease, or it doesn't respond to usual treatment like edema control, then you can look for other things. This is a condition called atrophy blanche, which is described as a porcelain-like appearance to the skin with telangiectasia. Again, that's in the gaiter distribution of the leg. So one of the more common causes of atrophy blanche is venous disease. But there are other causes, so it's not always venous. You usually end up compressing these people, and again, if it's venous, they usually respond, but not always. This is a terrible problem that you see mainly in people with end-stage renal disease called calciphylaxis, where blood vessels calcify and form terrible ulcers. It has to do with calcium and phosphorus metabolism, and in my experience, it does not respond well to treatment and is a bad prognosis. This is, again, pyoderma gangrenosum, which I mentioned earlier. There are different clinical forms of it. It can look like a pustule initially. It demonstrates a property called pathergy, which means that if you debride this, it's going to make it bigger. And it's going to make it worse than if you just leave it alone. It's often associated with inflammatory problems like inflammatory bowel disease. And it's one of those things that if you don't think about it, you don't diagnose it. Unfortunately, you can biopsy this, and there's nothing pathognomonic on the biopsy that will say, yep, this is pyoderma. You have to think about it and look for associations, and then sometimes just treat with things like dapsone or corticosteroids to see if you get a positive response. This is atypical mycobacterial infection. Environmental mycobacteria like Mycobacteria chelonia and fortuitum and abscessus that we used to see a lot of in Louisiana and Texas, probably still do, but they did when I was in ID training in New Orleans. And again, if you don't think about it, then you don't find it. So if you're treating somebody with a chronic ulcer and they're not responding, then the next thing to do is to biopsy it and send it for studies to include histopathology, usually to a dermatopathologist, and send it out, or do 2 or 3 punch biopsies and send one for culture also, and tell them, you know, if you're concerned about atypicals like atypical mycobacteria, be sure to mention that, because sometimes there are certain temperatures that they have to grow those in order to get them to grow. So we've talked a lot about chronic ulcers. Why would you put in a hospital-based wound care center? Well, according to this particular study back in '01, the wound care centers increase the probability of healing after 20 weeks compared to standard care, and they're less costly for a healed outcome than standard care. Realizing that there are people, I mean, there are varying levels of expertise when you're dealing with chronic ulcers. There are some people who are very, very comfortable dealing with venous ulcers or diabetic ulcers in their office, but if you're not, then a wound care center may be a good option for you. Apparently, we were not the first people who had the idea. This was the University of Pennsylvania back in 1904. They had folks with leg ulcers. Don't know what they were doing for them then, but at least they had a clinic. What can we do? What can we offer? Well, we can offer standard things like wound debridement, serial debridement, removing, again, biofilm, devitalized tissue, sutures, foreign bodies, reducing bacterial load. There are reasons that you can and should debride wounds in order to get them to. What you're trying to do is to move a wound that's stuck in the inflammatory phase back to a more acute wound that can, again, have a shot at healing normally. So there are local care and dressings. Lord, there are hundreds and probably thousands of different kinds. There are dressings with silver in them. They haven't, if you go to the Cochrane site and you look at whether there are good, well done randomized studies to show benefit from some of these things, what you'll find is that the evidence is either not there or it's not great. But there's still a lot of silver impregnated dressings that are used. There are dressings that are impregnated with medical grade honey, Manuka honey, and they seem to be helpful in some people. I mentioned cadexamer iodine, and that's one thing that is mentioned in this Singer article as being shown to be beneficial. So if you think you have a problem with increased bacterial load, then using cadexamer iodine sometimes along with systemic antibiotics is a reasonable thing to do. I will say that one of the reasons that I like wound care is that it's very collaborative. If you go to wound care centers, you will often find people who have years of experience with wound care, and nurses see things differently than physicians see things. I mean, they see the dressing when it's taken off, they hear things in history that physicians may not hear, and they will often have a better idea about what sort of dressing will work on a wound than a physician will, at least in my experience. So I usually float a couple of trial balloons and see what the nurse thinks about my ideas about local care and dressings, and if they're for it, we go with it, and if they have other ideas, and I usually go with them. Offloading, we talked about offloading with different sorts of devices. Compression therapy, which is probably the most effective of anything that we do for venous leg ulcers. Treating the underlying conditions, trying to get their diabetes under control, getting them to stop smoking, getting them to stop smoking, getting them to stop smoking. But there are some things that maybe you would recognize as being more advanced techniques. And the first of those is hyperbaric oxygen therapy, which we'll talk about in just a second. Negative pressure wound therapy, that's Wound Vac and sons and daughters of Wound Vac. There are different companies now that have devices like that draw drainage away from the wound and pull it together and enhance angiogenesis and tissue growth, and can be very helpful in certain wounds. Skin substitutes. This article, actually the appendix to the article by Singer, has a long list of, and you can get these products that are made from animal sources, from human sources, from human chorion. There are all sorts of different ones. All of them think that they're the best, and you just have to kind of figure out what your patient can afford, what you can get through your hospital, and what makes sense. Growth factors, platelet-derived growth factor is available, brand name Regranex. It's very expensive, but it's worth a shot in some patients who are stuck and you can't find anything else that's helping. I have a couple of patients now who are using it and seem to be getting some benefit from it, but it costs thousands of dollars for a little tube that you keep in the refrigerator. And so unless they have insurance coverage, it's probably not going to happen. Electrical stimulation and therapeutic ultrasound are in the literature. I don't use them at any of the centers where I go. It's not available, but it is talked about in the literature, and you might be interested in looking into that. So hyperbaric oxygen therapy, what is it? Well, it's not either of these things. People used to think you could just stick your leg in a hyperbaric chamber and that would help it heal. or that hyperbaric oxygen at the court side and a basketball game was the best thing to do. That's not what it is. What we're talking about is the whole person lying in what looks like a plexiglass tube. A monoplace chamber holds one person, and you can increase the pressure in there. You can treat people for the bends in a monoplace chamber. There are also multi-place chambers where they're big enough for several people to sit in chairs or on benches in the chamber, and you can increase the pressure. This particular illustration shows going from 1 atmosphere absolute up to, 3 atmospheres absolute. And this is interesting because it kind of harkens back to a study that was done in the late 1940s by a Dr. Barima, where he had the idea that if he could dissolve enough oxygen in plasma, then he might be able to serve the oxygen requirements of an animal without even using hemoglobin. Normally, your hemoglobin is loaded up with oxygen. It's about 98-99% saturated, and there's a little bit of oxygen that is dissolved in the plasma. But if you increase the partial pressure of oxygen by increasing the pressure to, as I said, 2 to 3 atmospheres absolute, then you can actually get quite a bit more oxygen into the plasma. So that's the oxygen dissolved in plasma, and he decided that he could put that to the test by taking some pigs and putting them in a multi-place chamber and then draining the blood out of the pig and replacing it with plasma. And what he found was that he could drain the pig entirely of blood and have only plasma being pumped through their vessels. And at, I think he was at 3 atmospheres. 3 atmospheres of pressure, the pigs were perfectly happy running around the chamber and no problems, because you only extract about that much oxygen or less from blood as it's pumped through the system anyway. So that's what we're trying to do, is to increase the dissolved oxygen in plasma and to create a gradient so that we've got lots of oxygen in the blood and the plasma. We have hypoxic wounds, and so we drive the gas down the gradient into the tissue. It diffuses out further into the tissue than it would otherwise, and it increases that partial pressure of oxygen in tissue, which we said is critical to wound healing. So there are some things that have been studied, and again, who the Center for Medicare and Medicaid Services in their infinite wisdom have decided there's enough information to cover for HBO therapy, and they are here. Chronic refractory osteomyelitis, meaning that you've treated it with usual therapy for at least a month, you're not making ground, and so you can add on this as an adjunctive treatment. Soft tissue radiation necrosis, osteoradiation preservation of flaps and grafts depends. Now that's, it has to be really acutely failing. Wounds with demonstrated peri-wound hypoxia, that's where you can actually measure oxygen by TCOM, transcutaneous oxygen measurement. And if you can show that it's hypoxic at rest, and then especially if you can put them in the chamber, the monoplace chamber, and measure what the oxygen in the tissue is like in the chamber, and show that it's improved significantly, then you can make a case for using HBO. Diabetic foot ulcers, it has to be at least a Wagner 3, we mentioned, and then critical limb ischemia. There are contraindications. Really, the only absolute contraindication is the untreated pneumothorax. There are some chemotherapeutic drugs that are contraindicated, but that doesn't come up very frequently in pregnancy. It hasn't come up since I've been doing this. So I poll the audience at the wound care centers where I go and ask them if you could say what you want to say to the folks at Grand Rounds about what to do if you're referring patients to the wound center, what would you do? And they said, these are nurses. And they said, send records. And if it's convenient, go ahead and get some of the preliminary studies, like the non-invasive arterial studies with ABIs. You can, if you want to go further than that, get segmental pressures, and that would be helpful. Venous Doppler studies, don't just send them for ultrasound of the leg, because what you'll get back is there is no DVT. What you want to say is venous Doppler with reflux studies. Asking the radiologist to specifically look for evidence of reflux. And then you can get labs. You can include some labs that look at the question of whether they're malnourished or not, like prealbumin and transferrin. If there may be osteomyelitis going on, you can go ahead and get a SED rate and a CRP. Plain x-rays don't hurt. And I think that's it. So, I don't know if we have times for questions or not, but if there are any questions, I'll be glad to try to address.
What about the use of oxygen masks, like pilot shoes at high altitude, that are sealed units, where you increase the amount of oxygen up to 100%?
Well, breathing 100% oxygen is...
Or less.
Yeah, breathing 100% oxygen will increase your oxygen in your blood to some degree, but nothing like what it does. I mean, if you go back and you look at the look down at the bottom in millimeters of mercury, PaO2 in millimeters of mercury. I mean, 100% at 1 atmosphere, 2,000 at 3 atmospheres of pressure. So the increase in the atmospheric pressure, or the pressure provided by the chamber, is critical to getting the gas to dissolve in the plasma.
But instead of using it in a room, use it in a mask. Get the vapor.
Yeah, you can't. I don't know of any way to do that. Now, if you're in an airplane, you're in a hyperbaric chamber, because you're in a pressurized chamber at altitude. But this is like going up to 2 to 2.5 atmospheres absolute is like going 33 feet down into water. It's that much pressure. So that pressure is critical to getting it to dissolve into the plasma. Yes, ma'am.
How often, when you are using the hyperbaric oxygen therapy, how often are you diving the patients, and should that be started in-house?
Good question about in-house. I think, and that varies from institution to institution. I think St. Vincent said when they opened the chamber downtown that if there were members of the medical staff who felt as though a patient needed HBO therapy and they were inpatients, they would not be denied that. And that would be people like people with necrotizing fasciitis, necrotizing soft tissue infections. And that, if you can start those, those need to be started as quickly as possible, along with surgery and antimicrobial therapy. Normally, what you do is you treat with HBO therapy every day, Monday through Friday. Takes about 2 hours out of your day, 90 minutes in the chamber, 15 to get ready and get to get dressed and get undressed. And I think that most studies show that unless you do it at least 3 times a week, you're probably not getting benefit from it. So there is a holdover effect where if you do it, you know, you're in the chamber for 90 minutes, you do get benefit that continues on after that, such that doing it once a day for 5 days is usually done. Now, if you've got somebody who has critical limb ischemia or a bad necrotizing soft tissue infection, you may dive them twice a day for like 2 or 3 days. But all of our patients with chronic problems, we dive once a day.
Thank you.
Sure. Yes, sir.
With the ulcers of neuropathy, are there any other factors that causes the ulceration other than just susceptibility to trauma?
Well, there are usually multiple factors going on in diabetics, like we talked about. They're uncontrolled blood sugars often. There's vascular disease, whether it be macrovascular disease or microvascular disease. There are problems not only with the sensory nervous system, but also with the autonomic nervous system, so that these patients often get dry, scaly skin because their autonomic nervous system is screwed up also. So I think a lot of those things, plus the fact that they don't produce growth factors like they should, they don't produce blood vessels like they should. There's just a whole lot of different factors that go into the reason that diabetic ulcers begin and don't heal well. Okay. Thank you. All right, I didn't wonder much.
No, you did good. You stayed right here. I had to point at you one time. Thank you very much.
Yes, sir. Thank you.